Sciences for the presentation of varicose veins. P. Venkateshwar garu to honor the dais.
Please restrict the time.
Good morning everyone. I am Dr. Geetha, second year from Prathama Medical College, presenting a case of varicose veins. Coming to the patient particulars, 49-year-old male, Lavya Kaddu, from the Usnabad, is former by occupation. He is admitted in the main surgical ward on February 2nd from Prathama Medical College with chief complaints of multiple tortuous dilated swellings over the right leg for 2 years. Pain in the right leg for from 15 days. History of coming to present illness, apparently asymptomatic 2 years back. Then he noticed multiple dilated tortuous swellings in an aspect of the right leg, which is of insidious onset. Swelling initially noted in the upper part of the leg, gradually extending to the inner and front of the leg and ankle. Swelling aggravated after prolonged standing, and the prominence reduces after lying down. Later, similar multiple dilated tortuous swellings are noted in the aspect of the left leg also, associated with sensation of heaviness in the limbs. Patient also complains of pain in the right leg from 15 days, which is of gradual onset, diagonal type, progressive in nature. Pain aggravated and prolonged standing and decreases by taking rest or lying down for 15 to 30 minutes. Pain was more towards the end of the day. History of night cramps were present. History of itching with eczematous changes and darkening of the skin, upper third inner aspect of the right leg is present. No history of itching, color change, edema, ulceration around the ankle, no history of bleeding from prominent veins, no history of fever, no history of lump or pain abdomen, no history of trauma to the leg or abdomen, no history of prolonged hospitalization, immobilization in the past, no history suggestive of DVT, no history of weight loss and no history of constipation. Past history, no history of similar complaints in the past, no history of diabetes, hypertension, coagulation disorder, tuberculosis, asthma, CVI, coronary artery disease. No history of major surgeries, accidents, prolonged immobilization in the bed. No history suggestive of DVT in the past. Coming to the personal history, married, belongs to low socioeconomic group, former by occupation, requires prolonged standing, takes mixed diet, normal appetite, sleep is disturbed from 15 days, bowel, bladder are normal, no addictions of alcohol and smoking. Coming to family history, no similar complaints in the family members, and not taken treatment previously for this condition, is not allergic to any contact ingest inhalants. Coming to general physical examination, 49-year-old male, conscious, coherent, cooperative, liquidity is normal, build average, height is 175, weight is 63, nutrition is fair. Skin, all over the skin is normal except for the upper third of the right leg. Hair is normal, dehydration is absent, performance scale is 80, ECG scale is 1. There is no pallor, icterus, cyanosis, clubbing, trigonometry, lymphadenopathy and piloedema. Neck veins are not enhanced. Coming to the vital data, temperature is 98, pulse rate is 82, regular rhythm, normal volume, normal character, normal arterial condition, no radiofemoral delay. All other peripheral pulses are bilaterally symmetrical and palpable. Respiratory rate is 17 per minute, regular rhythm, BP is 120/80. Is examining the right upper limb supine position. Coming to the local examination of both lower limbs, examining standing position and also supine position. Exposing from the umbilicus to the toe, examining from front, back and side, and coming to the inspection of the right lower limb, both lower limbs. Both limbs are equal in circumference, attitude of both lower limbs are normal. This is examination from the front, side and the back. Coming to the diseased leg, that is right lower limb, is large enlarged tortuous dilated veins are noted along the anterior and medial aspect of the right lower limb in great supinous vein distribution extending from the medial malleolus to the mid-thigh. Load varices are noted on the medial aspect of right knee joint. Eczematous changes with hypopigmentation noted on medial aspect of upper third of the leg. And collapsibility of the veins are seen on elevation of the limb 60 degrees. Morris's cough impulse test is positive, that is visible retrograde filling of the proximal part of the long saphenous vein is noted. No signs of pigmentation, eczema, ulceration, lipodermatosclerosis around the ankle, no signs of ankle flare and no visible dilated veins of the abdomen. Coming to palpation, no locus of temperature, no tenderness, no cord-like thickening along the course of the vein. Courier's sign is positive, that is positive cough impulse noted SHS. Next, coming to the test for varicose veins. Broadly tendon nerve test 1 is positive, that is SFJ incompetence, and coming to the perforator incompetence. Broadly tendon nerve test 2 is positive, that is perforators noted below the knee and upper leg perforators. They coming to neck, multiple tourniquet test, perforator incompetence noted below the knee and upper medial perforators of the leg. This is Pratt's test, is also positive. Figon's test is a crescent-like depression is noted below knee perforator. Short's test is a venous release felt just below the SFJ. Test for deep veins, modified Perthes test is negative, no cough, swelling and tenderness. Next, coming to the palpation of the peripheral artery system is normal. Auscultation of the dilative is no fluid. Lymph node examination not palpable inguinal lymph nodes. Examination of musculoskeletal system of right lower limb is normal. And over the left leg, there are some varices noted below the knee. Coming to systemic examination, examination of abdomen is normal. And external genitalia and for rectal examination is normal. Respiratory
Please
system
forget about general examination. Now time up. Come to your conclusion. What's the provisional clinical diagnosis?
So provisional diagnosis is a case of varicose veins affecting great stiffness vein distribution of the right lower limb with SFJ incompetence and perforator incompetence below knee and upper part of the leg without with some skin changes over the upper part of the leg without complications of TVT.
So big diagnosis. What's your clinical provisional diagnosis? So don't say so big diagnosis. What is the provisional clinical diagnosis?
It's a varicose veins of right.
Varicose. Define varicose veins. Define varicose veins.
Varicose veins, dilated tortuous engorged veins which are present in the.
What is the diagnosis? You have told only anatomical diagnosis. I want total diagnosis, total definition. Dilated tortuous engorged veins is anatomical part of it. What is the physiological part? Dilated tortuous engorged veins with reversal of flow. You say in the history, you said there is no loss of weight. How it matters in the case of varicose veins? Waste of loss of weight.
Any pelvic malignancies which is presenting with varicose veins and also.
You should be able to answer that. Any question you should be able.
Few questions in your history, Geetha. One important thing for everyone is that when we are presenting the history, which is in patient's own words, so you are used freely some of the words of scientific origin, like eczema and other things. See, you can say itching, that may be taken into consideration, but skin changes, you cannot put words. These are some of the things which you should be very careful in the history. It is only patient words which should be there in the history.
Please explain how do you do Figon's test?
Figon's test, first we have to understand the position, we have to see the blowouts, mark the blowouts first. Next, on supine position, elevate the leg, empty the vessels, and then at the level of marking, we have to examine the depression, like depressions of vessels.
First, you should mark the whole vein, dilated vein. In standing position, when the vein is full, you should mark it. Then empty it and feel the depressions. Then mark. What are the causes which affect the venous return to the heart?
Negative intrathoracic pressure.
Please speak in a way. What are the factors which help in the cardiac
Venous return.
Venous return to heart?
It is by the negative intrathoracic pressure and also valves which are present in the lower leg veins, which will pump, will direct the blood to up.
Next.
And also calf muscle.
Peripheral hearts. Next. What is the end arterial pressure? First you must say end arterial venous pressure, which is about 30 mm of Hg. Next, peripheral hearts. Next, venous valves. Next, negative pressure in the thorax. You got the diaphragmatic pull. Next, low right atrial pressure. Low right atrial pressure. These are factors which help the cardiac venous return to the heart. Which part of the veins the valves are absent?
Inferior vena cava.
And
Superior vena cava.
there is a valve always present. 80% of the population, a valve may be present in the external iliac. Okay. What are the different perforators? Name the perforators.
From below upwards, sir.
Yes.
Main Kushner, ankle perforator, and leg perforators, cockade, that is at 5, 10, 15 centimeters. And the next one is Boyd, below knee perforator, Dodd, above knee perforator, Hunter, adductor canal perforator.
Which is the biggest perforator?
SFG.
Yes.
Venous hypertension, ambulatory venous hypertension.
Local venous hypertension. How?
Venous hypertension is because of incompetence of the valves, perforators and valves.
There is a stasis of blood near the ankle. So in the foot, usually in the leg, whole of the lower limb, the venous flow is from superficial veins to deep veins. Whereas in the foot, it is the other way, from the deep to superficial veins. So near the ankle, near the medial malleus, there is a local venous hypertension because of the column of the blood, the weight of the blood from above. And the blood coming from the deep to superficial system there. What are the synonyms of venous ulcer? What are the synonyms? What are other names for venous ulcer?
Varicose ulcer,
Very good.
Geetha's ulcer.
What?
Geetha.
Gator's zone, that is different. Gator's area, Gator's zone is different. What is, by the way, what is Gator's zone?
It is the area around the malleoli, sir.
What is the importance of that? That is the area where varicose ulcer is more common. What is that? That is the area which is not supported by any muscle. The skin, subcutaneous and bone.
And constant perforators are also present.
Okay, very good. So the synonyms for venous ulcer is venous ulcer, varicose ulcer, stasis ulcer and gravitational ulcer.
Gravitational.
So all pronounced same.
This diagnosis should not be so big as sir said. So what it should be there is that the incompetency of the non-saphenous system on the which side, that has to be mentioned, and perforator incompetency. And you have written about the CEP classification. Can you briefly say
What is C? What is
C is clinical, sir. And clinical,
in your case what is the C?
C is S4, that is S is symptomatic. C is again divided into A and S. A is asymptomatic, S is symptomatic. And these two are again divided into 6, sir. In our case it is 4. That is skin changes are present. A is only eczematous changes with pigmentation.
C1 is?
C1 is telangiectasia, sir.
Right. In your case,
C4, sir.
what does that for? Already ulceration was there?
No, sir. Skin changes are present.
Only skin changes. Oh, not a healed ulcer.
No, sir.
What is resting venous pressure? What is ambulatory venous pressure? What is venous deep time? Can you explain? What is resting?
Resting venous pressure is which is normally standing or lying down position, which is normally present. That is it is around 20 to 30 mm of Hg. And ambulatory venous pressure on standing and walking for our exercise. This is around 80 mm of Hg.
Which is more? Venous resting pressure is more or ambulatory venous pressure is more? Which is more? What is the importance? How do you do the test? You cannulate a dorsal vein in the foot,
Ambulatory venous pressure.
then attach to a pressure transducer, then first measure the venous pressure when the patient is taking rest. The patient need not walk. What we call a tiptoe movement. By doing tiptoe movement is equal to walking. Then measure the perforators.
Types of perforators, direct perforators and indirect perforators.
Can you, apart from surgery, can you explain what is compression sclerotherapy and how will you do it? Compression sclerotherapy and how will you do it and what are the indications? What are the complications of varicose veins?
Complications of varicose veins. Because complications due to varicose veins is bleeding, calcification of veins, and thrombophlebitis. And because of venous hypertension, there will be pigmentation, eczematous changes, ulceration, lipodermatous sclerosis. If ulceration is chronic, it leads to squamous cell carcinoma, there is no marginal ulcer. And if this ulcer is chronic, it also leads to periostitis, talipes segments deformity.
Reading you have forgot.
What is the most common complication? What is the most common complication? What is the most common complication of varicose veins?
Most
Common complication. Thrombophlebitis. Why equinus deformity?
equinus deformity because of pain due to ulcer. Patient usually walk with the tip of the foot. Then there is a fibrosis of Achilles tendon and leads to equinus deformity.
In your case also there is a pain, isn't it? Why this pain?
Pain.
What about the modified purpose in your case?
Negatives.
Negative. It is not due to DVT.
No, sir.
No. Then why the pain? So that is most probably some thrombosis. In palpation, did you mention about any solid which are thrombus or anything which is palpable along the vein?
No, sir. I say that.
Okay. After confirming your making your diagnosis, how do you confirm it?
I'll confirm with the duplex scan of the right lower limb. It will indicate the septofemoral incompetence. By doing duplex scan, we can know the septofemoral incompetence and perforator level incompetence, and also we can see the reflexes deep in the system also.
Except the incompetence, what surgery you do?
Trendelenburg test.
What surgery? What surgery?
Trendelenburg procedure.
What is that?
Flush ligation of
What do you know by flush ligation?
we have to ligate the great subnasement as nearer to the femoral vein.
It's not that. It's not flush means you are not chopping it up. You have to ligate, identify and ligate 3 tributaries. What are they? Near the surgeon?
Superficial gastric, superficial circumflex iliac and extrude iliac.
Good. So you should not cross. So you should not leave any of those tributaries. Okay. What is the treatment for perforator incompetence?
For perforator incompetence, sufficient ligation of pocket dot, Clayton's procedure, and hook phlebotomy, and other procedures are sclerotherapy, foam sclerotherapy, and the newer ones is radiofrequency ablation of perforators and laser also.
What is sepsis?
Sepsis is subfacial endoscopic surgery, which is also done for perforators.
Perfect. So now tell about compression sclerotherapy procedure and indications.
Sclerotherapy, by using sclerosant, about 1 to 3% polydoc.
Pardon me, how much?
1 to 3%.
Please close to the mic.
Yes, you're right. What is that? Point?
Polydocanones.
What is that? What is the sclerosant used? Commonly, routine used.
Sodium tetradocyl sulfate or
Right.
what?
Right. How much? What percent?
It is available in 1 or 3%. We can dilute depending on the vein size.
Again, don't say you.
Yes.
I'm your examiner. Don't use you or we. I. Always say I. That is only nothing but training for the final exam. What are the indications for sclerotherapy?
Indications for sclerotherapy, small veins, thread veins, reticular veins, or any after major surgery, tendon surgery, any leftover varices, or
Recurrent and small. That is for sclerotherapy is mainly used for perforator incompetence, not for major this thing. Okay. What is the procedure?
procedure is take spinocyte about 0.1 ml.
0.5 ml, 0.3% of sodium beta first identify the perpetrator, something needed. Then you inject that
and immediately compress
apply a
site
pad,
of injection.
apply a pad, and then what advice you give the patient?
Then ambulate within 24 hours and compression bandage is applied for 1 to 2.
So ask the patient to walk immediately so that there will not be any intravenous extension. Then ask the patient to wear compression bandages for 1 month.
This particular patient, what? One second.
This provisional diagnosis has varicose veins, right lower limb. Did you examine the left lower limb also? Did you see any abnormality in that? Did you mention it here?
She mentioned.
Mentioned, yes. Mentioned. And present it external. Don't read from the text. When you take it from the patient, probably you will write down the entire history. But that is the story. But when you present the case, let it be external. And then don't be in a hurry when you present the. You are thinking
What is the etiology for the varicose? Etiology. Second. It's very simple. Secondary.
Abdominal malignancies, pelvic malignancies, retroperitoneal fibrosis, abdominal lymphadenopathy, because of the liquid thrombosis, and also congenital AD malformations due to genesis.
What are the causes for primary?
Sorry, till we came late, we don't know that we.